Sound verify చేయండి. Sound verify చేయండి.
ప్రస్తుతానికి అన్మ్యూట్ లో ఉంది, మాట్లాడొచ్చు, మాట్లాడితే మీకు వస్తుంది.
Good morning, everybody.
Yeah. Good morning, sir.
Okay. So we start. Another 2 minutes time. We'll introduce 1 minute.
ఇంకా తెచ్చేయాలండి. బాగుంది.
last time. Hello, that's sorry. Problems.
అరుణ్ చెప్పండి. మార్నింగ్
Satyam Prasad is there. Good morning, Ra.
Yes, sir.
Of the DR.NTRUHS University of Health Sciences. I am Dr. Chandrasekhar, Vice-Chancellor of the University. I would like to invite my batchmate, 1977 batch from Corporeal Medical College, for this first lecture, international lecture on ECMO. So I welcome on behalf of the university Dr. Suneel. I request Dr. Subha, she will read the biodata of Dr. Suneel Kumar and followed by his lecture.
Honorable Vice-Chancellor, sir, Dr. Suneel, sir, good, all the principals of the medical colleges, medical fraternity, and my dear students, very good morning to one and all. It's my honor and privilege to introduce Dr. Suneel Pooboni, sir, presently working as head of the Department of Paediatric Critical Care at Mediclinic City Hospital, Dubai, for the past 6 years. Prior to this, he was head of the Department of PICU at Rock Hospitals, SSMC and Mediclinic Abu Dhabi from 2017 to 2020. He was Professor of Pediatrics, Gulf Medical University, and currently Associate Professor Mohammed bin Rashid University, Dubai. He was founding chairman of South Asia, West Asia chapter of 2014 to from 2014 to 2017. He was consultant in pediatric critical care at University Hospitals of Registrar, UK from 2007 to 2017. Head of the Department of Pediatric Critical Care and established Department of ECMO at KIMS, Hyderabad between 2014 to 2015. Sir also published 40 papers in international journals and contributed to 5 books, including the 5th edition of Red Book, ELSO and another book, ECMO, A Practical Guide to Management by Sprenger. He organized national and international conferences. His interests are respiratory critical care, neurosurgical critical care, and ECMO. I welcome you, sir. Sir, today's topic is Way Forward in Critical Care Journey. Is ECMO possible in our setup? Over to Dr. Suneel, sir.
Good afternoon, everyone. At the outset, I would like to thank Dr. Chandrasekhar for making these arrangements and Dr. Sudha for her kind introduction. It's a pleasure to see all of you here today. Among you, I can see the faces of my batchmate, Dr. Satyavara Prasad, and my senior colleague, Dr. C.L. Venkatrao. So I'm very pleased to be here today. And thanks for the opportunity. So, without much of delay, I would like to start with the topic as such. For the past 25 years, I have been working in the field of ECMO. I will briefly mention about how things happened in my journey of nearly quarter of a century, and then move on to description of ECMO, indications of ECMO, and see if it is possible to do it in our setup, especially in a government setup. That is my focus today. So, why critical care? The reason why I have chosen critical care is, yes, we can work together as clinicians to certain extent with antibiotics and further oxygen therapy, etc. But when it comes to need of sustaining the life further and further, certainly we need to choose a chance, and this is where life and death will be decided. So that's my interest in moving on to critical care as my area of choice. I'm really impressed by this slide, which explains a lot about what happens when the disease process. For example, pneumonia sets in. To the right side of the slide, you are seeing. Can we recognize this? Yes, sir. So in the right side of the slide, we're seeing the unhealthy part of the alveolus during pneumonia, for example. So in a healthy part to the left side, there is a healthy alveolar mucosa, as well as the lumen is filled with air and oxygen, which contains oxygen, 21% oxygen, of course, lined by the alveolar layer and the type 1, type 3 alveolar cells. And to the right side, unhealthy and part of the alveolus is represented here, which the healthy mucous alveolar membrane is replaced by a mucous membrane here, so the gas exchange is not possible. The lining is very difficult to get through with the adjacent capillaries, and there is widened interstitial space as well with pro-collagen material, proteases, etc. Apart from this, as a result of this inflammation going on, various cytokines, human necrosis factor, etc., they get released into the alveolar mucous membrane as well, alveolar content as well here, resulting in the pulmonary edema. So there is no wonder from this picture to get back to the healthy alveolus, as you are seeing on the left side of the picture, it took quite a bit of time. The fortunate thing is this is not a homogeneous process, it is heterogeneous. So some of the alveoli are down whereas the other alveoli are diseased in this process. When the number of diseased alveoli gets more and more, then you need the treatment for increased need for higher ventilation settings and then on to advanced modalities like extracorporeal membrane oxygenation. So in critical care, we try all these measures for sustaining the life, starting from the fluid management, which is very, very important in an inflamed stage. As the capillary leak sets in, pulmonary edema also will sit in the part of it. So getting rid of the fluid during this phase will definitely help in improving the oxygenation. So other measures are also mentioned here like tone position. What do you do with the ventilator, increasing the driving pressure, mechanical power reduction, and all these various modalities, including pulmonary vasodilators, etc., we tend to try when there is significant hypoxia and hypercarbia. So at this time, we can think about a process. It is nearly 50 years old now. It's a mechanism of cardiopulmonary support to help in case of reversible cardiopulmonary failure for a period of weeks to months after failure of maximal conventional management. So this term of failure of maximal conventional management is very, very important because ECMO is an invasive process and currently it is a costly affair as well. So once we start this, there is only one way possible. They have to get better or they have to demise. Between these two. There is no intermediary way of coming out of it, apart from using it as a bridge for lung transplantation, heart transplantation, or VATS, etc. I would like to dedicate my talk to my teacher, Dr. Ramanujacharyalu. This was the picture from 2003 when I was talking at Corporeal Medical College, my alma mater, on ECMO at the time. He posed a relevant question after my talk on ECMO. He said, how much does it cost in India? Unfortunately, at that time, no one was doing ECMO per se in India. So I have to convert the figures from UK, which was around 2 lakh rupees per day, and then everyone laughed at it and said this because this treatment process is not going to come to India. But we wanted to make sure this comes to India. And in 2010, we established an organization called ECMO Society of India. So before we go for that, a little bit about our patients, why they die from. It's a worsening and uncontrolled process of disease. Iatrogenic causes also could be there in it as well, unable to support adequately and safely. It could be ventilator-induced lung injury, cardiovascular effects of the high ventilatory support, fluid overload and organ edema needed to support the cardiovascular function, and use of high inotropes, sepsis, global or regional tissue perfusion from the above effect. So we tend to see this when a patient is failing and we say that we cannot help them at this process and very close to declared death. At this stage, if the underlying process is reversible, still we can make use of ECMO at this time. Body organs have a remarkable capacity to sustain injury. If you provide, this is what I learned in the last 30 years. If you provide oxygenated blood, despite the fact the saturations are around 80, etc., keep monitoring the lactate as a surrogate of tissue oxygenation, keep carbon dioxide within limits and protect the brain, preserve the organ function by facilitating tissue oxygen delivery. So with this, as we do an ECMO, saturations around 80s with acceptable tissue oxygenation and reduce the metabolic demands of the body. That is important as well. The basic metabolic rate has to come down. Allow time for recovery, do no harm. So we have seen that in conventional trials also, patients tend to get better, and this could be with this mechanism as such. So when there is a failure of gas exchange, when the ventilators cannot help with that, carbon dioxide tends to build up, happens more so in case of asthma. I have seen patients dying due to uncontrollable hypercarbia or hypoxia, could be lung failure, or a failure of circulation, in acute heart failure. Cardiology colleagues will be able to get help from ECMO in those settings. I will discuss with them briefly. Sooner the better before it becomes irreversible. So the guru or the founder for this process is Dr. Robert Bartlett. We work very closely with him. We call him Bob. As Bob says, sooner the better, like within 24 hours to 72 hours after deciding this is becoming irreversible, start on ECMO, then it would be good. The chances of recovery would be good in that phase. Why did we lose some of our stalwarts like Balasubramaniam and others? Is because the period of identification of putting them into ECMO and sometimes complications also can happen during the process of ECMO. So it could be a combination of both of them. If the world is divided into two equal parts, then Indian subcontinent with our Southeast Asia here plus China, that contributes to half of the world population. So you can see how densely populated our area is, and the possibility of acquiring ARDS in this population, it is quite huge. So world in the SWAC region itself, it amounts for world population of 46%. SWAC stands for South Asia and West Asia, Africa. These are the three regions. I will mention about them when we come to the ELSO. So as we discussed, ECMO is nothing but supporting the organ systems in the presence of reversible cardiopulmonary failure. So the reversibility is very, very important here. When there is extensive fibrosis, for example, then it would be difficult to anticipate reversal, and the patients have to be on ECMO for a long period of time, or at some stage one has to think of lung transplantation at a reasonable time. I like this slide very much because this explains the whole process of ECMO. ECMO is done for two reasons. Basically, when there is hypoxia or hypercarbia, and can be done with arteriovenous, veno-arterial or veno-venous cannulations. So here you can see the blood coming from the venous reservoir. Here we collect it from the right atrium in most of the circumstances. It could be from the femoral vein going to the inferior vena cava as well. So the blood goes through membrane oxygenator. Gas or the oxygen is supplied as the gas here, shown in depicted in green color here. So gas exchange happens here, carbon dioxide removal and addition of oxygen, and it will be oxygenated blood will be supplied either to the lungs or the heart. In simplicity, this is what ECMO is. Just briefly about my journey coming to process of ECMO. I started from Corporeal Medical College in 1977 and then did my post-graduation from PGH Chandrasekhar in pediatrics. Then I moved to a Mandal Primary Health Center in Mahbub Nagar called Narwa. I stayed there for 1 year and moved on to Neelofar Hospital for 5 years. I worked here as assistant professor. Then I went to Pennsylvania at this time. I got an opportunity to be part of the ECMO collaboration at this time in 1989. There was a newborn baby in the same hospital needing ECMO because of severe meconium aspiration syndrome and inability to have gas exchange. The great person you are seeing to the right side is Dr. Vinod Putani. He was an attending consultant at that time, and he brought the ECMO team from Philadelphia to put the baby on ECMO and takes patient back to Texas. So the whole flight to the right side of the US Air Force, it brought the ECMO console, the one which you are seeing to the left slide, with all of them from the army to help the civilian baby. And the next day, and this was all over in the newspapers as Born on the Wings of Compassion, Air Force honors his request to help the baby. And so that ignited my interest in ECMO at that time, but I never thought it would become part of my life afterwards. Then I went for my further training at Leicester Royal Infirmary, where I nearly spent a couple of decades at Glenfield Hospital, which is an ECMO center, and at Sick Kids in Toronto, Canada. So both the places I practiced ECMO I learned ECMO. So that has been a passion for me to continue and bring this life-saving process to our country. So with that, with a similar-minded individuals from India, we started ECMO Society of India in 2010 at Mumbai with the objectives of training people on ECMO and make sure ECMO is done for ethical basis in reasonable period of time. We started the research programs and be a part of the central also in taking this process of educating people together and establish ECMO in our country. To the left side, you are seeing Dr. Gibbon. He was the founder of cardiothoracic surgery. This is the first heart-lung bypass mission in 1953. He operated on a patient with atrial septal defect for the first time on this mission. And to make our dreams possible, in the middle you are seeing Dr. J. McLean. As a third-year medical student, he invented heparin. Without that, the anticoagulation wouldn't have been possible today. And to the right side is Bob Bartlett, or Dr. Robert Bartlett, the father of ECMO, who is still living. So he continues to inspire us and be with us in the conferences. So these are the two logos here. The central one is ELSO logo from Ann Arbor, Michigan, and the right one is from the South Asia, West Asia chapter. When it was instituted in 2013, I was elected as the chairman and I led the program as chairman for the next 4 years. So this is about John Gibbon starting his heart-lung bypass mission. And this was the first ECMO patient in 1972. This adult patient was put on ECMO 1971. Following a road traffic accident, he had an aortic laceration, so he was managed on ECMO. You're seeing the ECMO console is almost half the size of the patient's bed here. From there, as time moved on, it became very, very tiny. And this was the first baby who went on to ECMO. And this baby was labeled as Esperanza, which in Spanish means hope. We always feel like Esperanza remained as hope to the ECMO community. And she was put on ECMO by Dr. Robert Bartlett. She was the first neonate who went on to ECMO. When I actively started doing ECMO from 1999 onwards, this was the ECMO setup, how it was looking like. It is very difficult to find the baby here. I understand the reason in the center, but covered with equipment, ECMO console. It was doing roller pump ECMO those days in 1999, and CRRT mission also is there in this, infusions also. So from this, the picture has changed. Currently, the ECMO consoles are of this size. The 4 different ECMO consoles are seen. They have been miniaturized, and it is very easy to transport it from place to place as well. So when we think of ECMO, always we feel that after effectively utilizing the available medical options, afterload reduction therapies, right balance of inotropes and lucitropes, when we see that the balance is getting distorted and increasing inotrope requirement is there, then we have to think about ECMO at the right point of time without delay. The sooner it is started, the better it will be. I always understand the priorities in healthcare are primary care, then the last comes as secondary care and tertiary care. But we're also seeing cardiac surgery, ventilation, dialysis, transplants, oncology care, which were of a very lesser degree seen in the community nearly 30 years ago, 40 years ago. Now almost many hospitals can afford doing this in the corporates and in the government sector as well. So great appreciation for that. So along with that, our thought process is even ECMO should be part of it. When lives can be saved by using all the critical care skills we learned so far, by dedication, team effort, stabilization, and we have to make sure permissive strategies are needed here also, optimize everything, and convalescent is very important as well during this process. But why this talk is, ECMO is a subject by itself, like cardiothoracic surgery. This is a subject by itself. It cannot be learned within 2 days' time. I hear from people like, I can come for 2-day workshop, I want to learn ECMO. It is not possible because this is a subject. Thorough understanding is needed. Preceptorship at another center, following them while a patient is on ECMO is important. Selection of ideal cases. Don't select a case as a first case as a case with fibrosis or irreversible cause. Then possibility of failure would be high. And principles of asepsis are very, very important here because we lose nearly 20 to 40% of our patients secondary to infection. So I cannot stress enough about asepsis while we are doing this process. And the protocols, there are certain established protocols which we need to follow. Share the experience. Sharing the experience in Indian setup is very much needed here. I certainly recommend it for resource limited settings, but not for resource poor settings, because there is some cost involved in this also. Having facilities for ECMO means ability to provide maximal conventional management. Sometimes in pediatrics, we tend to use high frequency oscillatory ventilation and inhaled nitric oxide therapy as well. But in adults, inhaled nitric oxide therapy is also being used for pulmonary hypertension. Retrieval facility should be there, and conventional retrieval mobile ECMO if it is possible. Multidisciplinary team adhering to protocols, equipment, because it is a discipline by itself. So once we think that enough is enough, at the right point of time, we know the patient is failing, ventilation is failing, or cardiac support is failing, lactate is increasing, then it is a time to think about ECMO. There are two types of criteria I will mention about it. When you start considering ECMO and when you start putting the patient on ECMO. Do the ABC first and get the conventional management right, and then think about ECMO at that time. Initiation at the right time is very, very important too. The most important ECMO team members are, besides the ECMO director and ECMO coordinator, ECMO perfusionist, specialist nurses. These are the critical care nurses in the Indian scenario, trained in ECMO as well. ECMO intensivist and ECMO surgeon. These are the principal people who should be there in the ECMO team with additional support. As you can see in this slide, adult intensivist, pediatric intensivist, cardiac surgeons, blood transfusion services in the core team, supported by ECMO specialist nurses, which are providing 24/7 care with the perfusionists and other lead specialties such as cardiologists, nephrologists, surgeons, medical personnel such as radiologists, microbiologists, nutritionists, and labs. They are very important as an ECMO team. This is because the interpretation of the images on ECMO are different. The microbiologists help. We need it for time to time for keeping infection under control. These patients should be fed enough by all means with either gut we prefer. If not, total parenteral nutrition also is needed in this case. Similarly, the way cardiologist has to interpret the ECMO images of the heart are different. As we are sucking the blood of the right atrium, for cardiologist it might look like the right atrium is empty, but it is really not empty because we are sucking the blood out of the right atrium. So, in preventing and treating infection, this is my view on infection. We live in a bacterial world where we will never be able to stay ahead of the mutation curve. They have been living here for billions of years, and we came here few hundreds of years ago as well. So we cannot ask the bacteria to disappear all of a sudden. They're not going to do that. That's a fact. So make the environment infection free as far as possible. If you think OT is the right place where you feel it is free of infection, then think of similar facilities in the ECMO ICU for preventing the infection. Same safeguards over here as well. So once your infection is under control, then ECMO survival rates will be up by 20 to 40%. In Indian scenario, this is a universal problem not only in India, but there are ways to tackle with it also. So for this, I have practiced here when I was in Hyderabad, and with the team spirit, blame-free culture, with physicians' will, and even our IRs, cleaners, sweepers, they also play a lot of role in keeping our environment infection free. ECMO works by taking over the function of the ventilator when the gas exchange is very, very difficult and not happening, and taking over the function of the heart where inotropic requirement is excessive and it's not, the heart is not able to provide enough oxygenation to the body. So it provides rest to the lungs, rest to the heart. So it helps to support the tissues nearly adequately and safely. So the considerations are when it is a reversible process, once you have completed your conventional management to the maximal extent, if the patient is sufficiently sick enough to warrant extracorporeal life support or even limited hibernation is contraindicated, that is difficult. As many other organ function justify heroic measures, that is the time we need to consider ECMO. So the ideal ECMO candidates are acute disease process which is reversible, no comorbid disease as far as possible, minimal mechanical ventilation duration, unresponsive to best conventional management,
ఆల్రెడీ ఇచ్చేసామండి.
and increased
అందరూ ఉన్నారు, వాళ్ళకి ఇచ్చాము.
mortality without ECMO more than 80%.
థ్యాంక్ యూ.
So in those conditions, we need to consider ECMO as ideal candidate. Indications for ECMO are oxygenation index of 40%, I will mention that very briefly in the next few slides. Patients with mortality risk of more than 80%, PF ratio of less than 100, AA gradient of more than 600, Murray score of 3 to 4, etc. So these are the objective criteria for you. When your patients are satisfying these criteria, it is time to think of placing them on ECMO if facilities are available. For the respiratory ECMO, there are two circumstances. When you consider ECMO, when the risk of mortality is more than 50%, with these above mentioned criteria, PaO2 by FiO2 of less than 150, etc., or ECMO is indicated when the risk of mortality is nearing 80%, with a varying PaO2 by FiO2 ratios, Murray score of more than 3, oxygenation index of more than 30, etc. Cardiac ECLS in a phase of cardiogenic shock, persistent shock despite treatment for 6 hours, then it is a time to go for ECMO at that time. Sooner the better. Consider ECLS when the mortality risk is more than 50%, or inotropic scores are more than 20, lactate levels more than 4 millimoles. In our practice, we found the lactate levels are very, very useful markers, and the trend of lactate is very important than a number of by number itself. Definitely ECLS when the following criteria are satisfied with that. Among them, the lactate levels are just more than 7 millimoles. Intractable arrhythmias with shock. Intractable means you have tried your medical management, not helpful. Shock, not helpful. Go on to ECMO. Failure to come off cardiopulmonary bypass with OR. Yes, you can seek ECMO support till the heart recovers. VADs in place with severe respiratory failure and massive pulmonary embolism. These are the indications for going on to ECMO for cardiac support. Oxygenation index is mean airway pressure times FiO2 times 100 divided by post-rectal PaO2 in millimeters of mercury. So when it is exceeding 35 or nearing 40, that is the time to think of ECMO. In neonates and pediatrics, it holds very well, but not in adults. So for the sake of adults, we have devised Murray score. There are 4 parameters here: PaO2 by FiO2 ratios, chest X-ray, PEEP, and compliance. You can measure them easily, and all these 4 criteria are given different scores. When the total score is exceeding 3.5, then that is the time to think of ECMO and placing an ECMO. For the Caesar trial, we followed it. To the left side, you can see the chest X-ray, how it can look like before going on to ECMO. So ECMO can be done in various scenarios, in various ICUs. ECMO support can be seen here in the respiratory ICU, cardiac ICU, medical ICU, surgical ICU, emergency room, neuro ICU, neonatal ICU, pediatric ICU, transplant ICU. So there are indications for ECMO in all these places. Let me very briefly go through this. In the respiratory ICU, the most important factor for us is ARDS, when ventilation is not able to achieve gas exchange. So, and it is causing ventilator-induced lung injury. That is the time to go on to this. As an example for this is our recent COVID, and before that H1N1, which keeps happening again and again too. And there are many more diseases to come also. So there are severe pneumonias following trauma as well. This can happen. Airway disease like status asthmatica. This is one indication which I found ECMO very useful, because when the carbon dioxide exceeds certain limits and your bronchodilators are not going to help the situation, there is no way you can save the patient. Patient can die. At this time, as there is reversibility, if they go on to ECMO, within 3 to 4 days time, they will come off ECMO intactly without any problems at all. So if a facility is available, this is another very important and satisfying situation where our survival rates are 100%. Pulmonary vascular disease such as pulmonary embolism, yes, ECMO is the choice to go. Specific diseases to quote are H1N1, COVID-19 following failure of ventilation, asthma, pneumococcal pneumonia, Legionnaires disease, PVL, staphylococcus, pneumonia, Ehrlich syndromes and vasculitis, etc. So our lungs are more or less like this. So when there is so much of whiteout in the lungs, there is nothing ventilator is going to help in these scenarios. So this is a patient on ECMO with two cannulas, one in the venous system and the other in the arterial. ECMO in the cardiac failure. Cardiac reasons, post-operative cardiac surgery, failure to come off bypass in case of myocarditis, congenital heart disease in the stabilization process before any interventions are thought of, refractory arrhythmias whenever anti-arrhythmia medications are not helping to come off arrhythmia, cardiomyopathies as a bridge to transplant or to VAD, the neonatal myocardial infarction, yes, we did come across this, and ECPR, ECMO as an extended CPR. Once there is no response within 15 minutes, then a patient can be placed on ECMO. Especially helpful in case of in-house cardiac arrest here. Post-operative support for biventricular hearts, successful cardiac ECMO is possible when extended cardiopulmonary bypass is needed in these cases, or low cardiac output syndrome. Post-operative support for univentricular hearts are also possible as a patient's anatomical diagnosis and operative procedure are imprecise guides to reversibility of ventricular dysfunction. So if the surgery is inadequate, go back and revisit at the right time when it's stable. Cardiac cath can be done, CT angio can be done, myocarditis also. I've seen patients with myocarditis dying in front of my eyes. So these patients tolerate inotropes very poorly. You cannot give a huge amount of inotropic support on them. As the heart is diseased at this time, with the inflammation of the myocardium, they cannot tolerate high use of inotropic agents. So if they go on to ECMO, yes, the survival rates are much better. ECMO should be available as a rescue modality in these cases. And SVTs and arrhythmias, we talked about them. When conventional medications are not helpful, then you can seek support on ECMO. In cardiomyopathy cases too, either for recovery or bridge to transplant, we tried this. ECMO in septic shock, this is possible as well to support them on ECMO, but our results are not very good. Like 40% is the average survival rate in ECMO patients when ECMO is used in cases of severe septic shock. ECPR mentioned about it when CPR is taking more than 15 minutes. When your facilities are available, you should alert your ECMO team so that they can cannulate as soon as possible. There are more than 20,000 patients in the ELSO registry on ECMO as part of the CPR, with the survival rates 42% discharge home and 60 to 70% to decannulation. Elevated lactate is a very good indicator of anaerobic metabolism, in other words, tissue hypoxia. So when it is building up more and more, definitely the heart and brain need support during this time. Adult cardiac ECMO. In acute myocardial infarction and interventions for myocardial infarction, especially when there is cardiogenic shock, at those cases you can support them on ECMO, because you are working with a infarcted part of the muscle which is under stress, and we are asking that stressed myocardium to contribute to the cardiac output. So at a certain time, when the heart is not able to do that, then we can support them on ECMO for a few days till the myocardium recovers. The results are much better with this. Post-cardiotomy and myocarditis, acute pulmonary embolism, arrhythmias, poisonings, and hypothermia. These are the indications in the adult world. In cath lab, for complex percutaneous coronary interventions, complex transcatheter aortic valve implantation, cardiac compromise during ablation procedures, cardiac catheterization to diagnose residual lesion on ECMO is possible, and biopsies, LV and RV biopsies, and balloon dilatation to pulmonary valve resulting in post-procedure pulmonary edema. So these are some of the indications when ECMO can be thought of. Rescue PCI in cardiogenic shock and complex high-risk PCI, elective but complicated PCI crashing situation. Complex high-risk PCI cases, left main coronary artery disease associated with high-risk patient for CABG, poor LV, poor lung function, morbid obesity, age, combination, etc. I am aware of patients weighing around 300 kilos going onto ECMO as well. Yes, those patients do exist. In the Middle East, I have seen them. The goals of hyperdynamic support from the complex high-risk PCI are stabilizing the systemic perfusion till the heart recovers, balancing the myocardial perfusion demand versus supply by augmenting the perfusion and creating window to perfuse complete revascularization. So ECMO is in ICU as a bridge. Sometimes the heart may not recover. At that time, we can think of LVAD, RVAD, BiVAD as per the necessity, and or lung assist device as PAL, or heart transplant, lung transplant, heart and lung transplant. This could be an intermediary mechanism. In poisonings also, it is very helpful. Calcium channel blocker, overdose, beta blocker overdose, sulfas poisoning. It has been tried extensively in cases of sulfas poisoning with a very good survival rate in these cases. Unfortunately, the patients happen to come from poorer communities, but still there are charitable organizations which help putting them on ECMO, contributing to their life. Aconite poisoning, cardiotoxic seed poisoning, and insect bite leading on to shock or ARDS such as snake bite, scorpion bite, etc. In those cases also, ECMO is quite useful. Elective ECMO for these complex repairs, complex tracheal reconstructions, complex bronchial repairs, cardiac shunt procedures, bronchoalveolar lavage in case or needing hyperbaric chambers. These cases ECMO would be useful. For tracheal reconstruction, you can see these pictures. So when there is major need for going on to this, you cannot ventilate this patient as surgeons have to operate on the trachea. So you can successfully, place them on ECMO till the surgery is complete and they can come off till when you are ready to ventilate the patients. Neonatal and pediatric ICUs, there are indications of the respiratory and cardiac uses here. Primary pulmonary hypertension, secondary pulmonary hypertension due to meconium aspiration, hyaline membrane disease, congenital diaphragmatic hernias, etc. Severe air leak syndromes and the severe pneumonias. Contraindications are prematurity less than 34 weeks gestation, because the incidence of intraventricular hemorrhage tends to be high below this period, hence we don't recommend. Low birth weight less than 2 kilos, but it is going down to 1.6 kilos in current times. IVH and coagulopathy. If the intraventricular hemorrhage is more than grade 2, then we don't advise putting them on ECMO. And if they are ventilated for more than 7 to 10 days, it is a relative contraindication for going on to ECMO, as fibrosis already tends to set in by this time. In pregnancy, ECMO can be made use of in those cases of ARDS during pregnancy, cardiogenic shock, pulmonary embolism, PPH, and eclampsia. In these conditions, ECMO can be utilized to provide tissue oxygenation till the underlying condition resolves. There are certain ways we tend to cannulate these patients, because the pregnant uterus can put pressure on inferior vena cava. So we need to tilt the patient slightly to the lateral side for getting the cannulation at this time. But it is certainly an underused modality in saving pregnant women by not utilizing this technology. And extracorporeal membrane support for organ retrieval. This is my last slide in the uses here. So as I know where our center is also our state is also utilizing transplantation from deceased donors very often nowadays. I hear about these stories. So in those cases also, for preserving the organ utilization, organ use, after declaration of the death, we can put them on ECMO for preserving the organs for a longer period of time. So that is about the uses of ECMO. And as I mentioned, ECMO education itself is a very big process, as it is a division by itself. So the most important things we tend to learn and practice during ECMO. I'm just mentioning here, due to shortage of time, I'm not going at depth. Each one is a chapter by itself about the cannulation, anticoagulation, daily management and ECMO, lung recruitment, multi-system management and ECMO, weaning process, decannulation, that is getting the tubes off and putting the patient back on ECMO and minimal inotropic support. This is all the science of understanding and running ECMO. Keeping the skills up to date in dealing with ECMO emergencies is very important, and we do organize skill programs and simulation scenarios in different sets up to keep the proficiency. Extracorporeal life support organization recommends each ECMO center should do more than 20 cases to keep their skills up. But in case you are not, then you can make use of simulation to make this process happen. So the subspecialty related education is needed as well for training them for our interpretation's sake. Radiologically, those pictures are different, and you have to interpret them in a different manner compared to conventional radiology. ECMO related nephrology, ECMO related cardiology, and surgical specialty. So if one establishes a unit of ECMO, then getting our professional colleagues acquainted to what information we need in ECMO is very helpful. Nearly 15 years ago, as an organization, we started with ECMO education in India. Before that, yes, ECMO was being used as well, but that was as a cardiac ECMO for extended cardiopulmonary bypass. Institutions such as Narayana, they have been using it at that time, but not for respiratory reasons. Very few respiratory reasons are non-existing. So from there, we started training. There are other sister institutions which also have been training. We conduct annual, biannual. Now we made it 4 times in a year. Teaching faculty are national, international, with our passionate and motivated doctors, perfusionists, and critical care nurses from India and abroad. We're all teaching faculty and team. We trained not only our staff, but from other countries from Iran, Oman, UAE, Russia, Vietnam, Bangladesh, all these countries. There are doctors who came here and got trained. Many of our trainees are cardiothoracic surgeons, intensivists, cardiologists, and surgeons. These are the main divisions besides perfusionists and critical care nurses, because we are all one team and it is one science, so everyone should know this. The current training program we are organizing at ECMO Society of India is a 7-day program, 4-day online and 3-day on-site with the dedicated staff, interactive, simulation-based, web-based interventions, and with limited numbers. National and international faculty participated executing this program. We have our ECMO Red Book, which is like a Bible or Gita for us. It is an international edition from Ann Arbor, Michigan. So it is updated very frequently. to make the science up to date. From Indian aspect, myself and my colleague Pranay Oza, as editors, have brought out this book, textbook of ECMO, for our Indian scenario. Were the chief editors, and there are other colleagues who have been helping us as well in this. It will be in the market very soon. So the lessons in Indian scenario were learned, or we get cases here as late referrals, suboptimal times in negotiations. Cost is a huge problem. I will deal with that in a couple of slides. Entry criteria are not very strict. Sepsis is a major issue too, and transport issues are also there. Cost issues, we are very thankful to the corporates for embracing this program and establishing in many of the corporates for giving it a life. But the cost is around 1 lakh rupees per day, around that. What I am talking about here is how much it costs for putting a patient on ECMO. The cost of our circuits, if we make a circuit, is around 60,000 rupees. Custom packed units in India cost around 1.3 lakhs to 2.5 lakhs if it is a different mission, but the minimum is 1.3 lakhs. If you don't want to assemble, and if you want to buy a custom packed circuit. Usually circuits last for us for 10 days or more, and there are instances where they lasted for 60 days also on ECMO. One might require to change either pump or oxygenator, which costs 10,000 to 70,000 rupees per pump and 35,000 rupees per oxygenator. So recurring expense for blood transfusion are 2 to 3,000 rupees per day. So with this, actual average runtime as per ELSO corporates is neonatal ECMOs cost around 6 days to 10 days, 2.75 to 3.75 lakhs. Pediatric ECMOs 3.5 to 5 lakhs minimum. So the cost goes on like that, and the current cost is approximately around 1 lakh rupees per day. I would like to put it this way: how much it costs for you to run the ECMO program, ECMO per patient. The actual cost of ECMO is for the disposables. Mission cost is 20 to 30 lakh rupees, which is not very different to a ventilator cost. Manpower cost, 3 staff 60 to 70,000 rupees per month. In government setup, this is not an issue for you. Maintenance cost, annual maintenance contract and recovery cost, additional cost due to blood transfusion 500 rupees to 2,000 rupees daily. So the realistic scenario, ECMO initiation is around 1.5 to 2 lakh rupees on day one, and maintenance cost around 5,000 rupees per day if you are not putting into the manpower cost or the base cost as such. It is not a costly process to do if you want to do in your own place. So let me put it this way: how much ECMO therapy cost is the cost of the ECMO console, which is similar to a ventilator cost, and ICU space, workforce, circuit tubings and cannula as one-off cost, blood products and heparin as the recurring cost. So public hospital scenario, the cost of disposables could be 1.7 lakhs, cost of cannula 50,000 rupees, judicious use of antibiotics, no additional cost for blood transfusion, maintenance staff, etc., because they are all part of the public hospital. Best place to do cost-effective ECMO with limited resources is probably public hospital scenario, with a which will be accessible to a middle income group persons as well. So that is our destination. So initially itself I mentioned it has to be resource limited settings we can do, but not resource poor or where there are no resources we cannot do ECMO in those places. Needs one dedicated man who can change the scenario. Why public hospital institutions means services are available, specialists are there from all disciplines, experts are with you. You can do CRRT, it is part of your programs. Consumables, blood and blood products are there. It needs commitment. So for minimal extra expenditure for disposables, you should be able to run this program. Corporates, they set up centers in different cities, and critical care practitioners, cardiac surgeons are available. Uniformity in price, I mentioned around that. They all maintain similar prices. It is need of the hour. So with that, Currently, we have established more than 100 centers in India, and more than 1,500 cases are done in India per year, every year. So this is the data we know. As we get this data for the ECMOs, our initiation and discussing with our trainees, we get this data. But these are the number of cases being done in our country. So India as a country, we learned and we will continue to learn with dedication, learn by observership at other centers. Simulation is very much necessary to keep skills up to date. Attendance at courses in India and abroad and help is available from with our ECMO Society of India and other places, and WhatsApp, Facebook, Google, and via personal phone numbers. So our vision is, instead of saying that ECMO is not affordable in India, why can't we make ECMO affordable in resource limited countries and let resource limited countries afford ECMO? One of the great examples is Taiwan, which has a similar GDP like ours, but it is a national program in Taiwan. So as part of the extended ICU care, ECMO is offered to all the needy patients in Taiwan. But this is my personal belief and my personal slide. I don't want to use it as a tool to bankrupt the family. There may be people who have to sell out their livelihood earnings for the current day of affordability of ECMO. So I don't encourage that. That is my philosophy. Yeah, with the innovations, make sure it is accessible to people, and we are working on it. It needs your support if you can start it in the government scenarios here. The challenges are, ours is a huge country with variable healthcare provision, financial constraints are there, uniform transport facilities are needed, and there is a huge learning curve too. Future wise, these are not the end. These epidemics and pandemics, they are not the end. Many more are going to come, and we should be prepared. There are many more pathogens awaiting to become epidemics and pandemics. ARDS is a common final pathway for us to encounter rational utilization of healthcare resources to move extra mile forward is needed. There's so many unanswered questions, and we need to find answers. That's why research is needed. So in critical care scenario, in resource limited settings, learn the technology as experience cannot be obtained with experiments. Ethical practice is very much needed. Select the right equipment and disposables. Bulk purchases such as Walmart principle, which Narayan Vidya is practicing, helps in bringing the cost low. Charities and insurance schemes, they are helpful too, and also and innovations are possible in the current setup. So we started this program of Atmanirbhar Bharat in a ECMO field at our center in Mumbai by manufacturing membrane oxygenators, manufacturing the cannulae, and improvisation of using tubings from cardiac surgical practice with this. So we are hopeful we will be able to bring down the cost of consumables by 1/5, including the ECMO console to 1/3 of the ECMO console cost. ECMO is not a mission run with the help of a perfusionist. I know about my colleague, respected colleagues, who can think of this way, but it is not so, because it is a huge science. It is not making families ending up bankrupt, and it is not a status symbol as well. So once we are prepared and we have a zeal and passion to move and take our patient journey a little bit forward, when critical care is not helping to keep them alive, this is one of the ways we can explore. Our journey is long, but we will be able to reach there when the central organization of ECMO from Ann Arbor, Michigan, wanted to establish a regional center, a regional chapter. In 2013, we established South Asia, West Asia, Africa chapter of ELSO, and I was the founding chairman for the first 4 years. This is in 2014 when we conducted our first international conference of ECMO or our SWAC ELSO here. We took aims as one of the areas for me to experiment AIMS Bhubaneswar. For the past 6 years, we started ECMO with our trainees establishing the ECMO program over there, and they are. This is like why I'm quoting. This is one of the government organizations, and they are successfully running the ECMO program over there. I'm proud of them. I've been associated with AIMS BB Nagar as well. So take home message is in cases of potentially reversible causes of acute respiratory failure when your ventilator doesn't work, and then cardiac reasons also when the criteria, the objective criteria are satisfied at the right time. If you have the right facilities, we can embrace upon ECMO. In the world, there is huge experience. More than 250,000 cases have been placed on ECMO for various reasons. You can see here as adult, pediatric, and neonatal age groups with varying success rates. In general, the success rates are around 60% for pulmonary reasons and 50% for cardiac reasons. So this is when death is 100%, then 60% of those cases can survive and 50% of those cases can survive. With infection, our numbers are going down by 20%. So if we control infection, and then our numbers would be better off. So these are the figures at Glenfield Hospital where I work. In neonatal population for respiratory ECMO, survival rates are 95%, for children and adults 70%, and cardiac ECMO, neonates and children 67%, adults 40 to 50%, ECP are also between 40 to 50%. So in resource limited countries, certainly it is possible having a vision, team spirit, perseverance, making progress, learning from experience, we can make things possible. We learn and will continue to learn. Unless you liberate yourself from the traditional thinking and open up your imagination to dream, new progress cannot be made. I thought of these two suggested approaches. If your units are compatible with an infection control environment and have compatible disciplines, intensivist and cardiac surgery, consider training as a team and prove yourself as a team of ECMO if it is possible. Secondly, the NHS model, National Health Service model, with a central team, a national ECMO center or a state ECMO center for the AP state. Cases will be referred over there, and subsequently from their case, they can be referred to the nearest available ECMO, certified ECMO center. So these are the two possibilities I can think of at this time to maintain it as a quality controlled program and to keep the sanctity of the program too. Appropriate training of the entire team is necessary. We cannot neglect critical care nurses as they are the pillars. They are next to the patient round the clock and they are looking after. So they are also very important. I am mesmerized and really impressed by these two quotes of our beloved ex-president Abdul Kalam. Don't read success stories, you will only get message. Read failure stories, you will get some ideas to get success. And it was very true in my case and continue to be true. So this is my last slide. Dreams are not what you see in sleep. It's the thing which doesn't let you sleep. Thank you very much for your time, precious time, and being with us to see if this is possible and can we make this advanced step in future. With my teacher in 2023, felt that it is very difficult and cannot, and not only my teacher, my other colleagues also, everyone felt it's not possible in India, but with our efforts, yes, it should be possible in India too. Thank you very much for your attention.
Thank you, Dr. Suneel, for his excellent presentation on ECMO. Many of us will be thinking that it's very costly, as you said, bankrupt the people. I think definitely the time has come that even ECMO can be started in the teaching hospitals. So, hardly costs about 20 to 30 lakhs. It is a dedication that is required for the institute, particularly involving the anesthesiologists and the cardiologists and the pediatrician, cardiac surgeons and all. So definitely we take your suggestions. I request you to interact with Dr. Suneel Kumar for further queries. Thank you. Thank you. So if there are any questions, I'm very happy to answer and share my views on this. Most of it is science, and I shared my personal views on this as well. I may be wrong, but I wanted to share what my thoughts are to make this process possible in India within the available resources. Future is bright with our innovations and making Atmanirbhar Bharat steps with respect to self-confidence measures in doing ECMO. In future, we should be able to extend it to the use of middle class communities too.
Yeah. Sir, can I speak?
Please.
Yes, sir. Good afternoon, sir. This is Dr. Arif Pasha, Critical Care HOD from NRM Medical College, sir. Sir, really heartfelt thanks for our esteemed speaker, sir. Because in this, and I'm deeply grateful to our respected VC, sir, for giving this excellent session for us, sir. So in this era of critical care evolving rapidly, your insight really expanded our understanding, sir. And also it has given an hope that there in this resource limited settings also we can have an excellence in achievable and commitment. Sir, regarding coming, because we have conducted a couple of years back, we have done one case, sir, in our medical college, a pregnant patient, sir. So who has went into refractory ARDS, sir, with severe hypoxemia. So we could able to do, because we got a rented thing, sir, rented thing, that ECMO machine at that time, because it's around 8 years back, sir. So it was really, it has costed, we could able to maintain around 4 to 5 days, which has costed around 5 to 6 lakhs, sir. So as with your suggestion with this Atmanirbhar and our Indian consumables, hopefully that cost may come down, sir. So,
Yes,
and we can, yes, sir, we can 100% better initiate, because an initiating, having an awareness session like this and initiating in the medical colleges as well the government hospital, it will be very helpful for the scratch level of the people, poor people, sir. It will be very helpful. Thank you, sir. Thank you for giving this session. Thank you, Chandrasekhar, sir. Because I am one of the student of Kannur Medical College, sir. I'm the student of Chandrasekhar, sir. Sir, thank you, sir.
thank you, Bhash.
And we are fortunate because in a couple of months from NRM Medical College, our management as well as Dean ma'am, Lakshmi ma'am, as well as Sino sir is very courteous, and they are going to buy this ECMO machine, sir, in a couple of months, sir. So hopefully we'll be attached with the university as well as we'll take the suggestion from you, sir. Thank you.
Yeah, that's a good news, Dr. Pasha, and congratulations, because
Thank you.
you have the mission and train the people. Training the people is very, very important for the ECMO program and ECMO emergency. So when the team is ready, plus infection control environment, those are the ideal conditions needed for starting the ECMO program. Then you can do this. Consumables are a part of it. If you go for custom made, then it costs high. But if you have a perfusionist who can assemble, the ECMO circuit is nothing other than cardiopulmonary bypass circuit, which you use. I heard it costs around 2,000 rupees.
Yes, sir.
Yeah. So oxygenators, we don't advise on the same oxygenators, because the ECMO oxygenators tend to run for days to weeks to months also. I had times when it ran for 60 days. So these consumables, they cost around 50,000 rupees, 60,000 rupees, like that. Yes, this would be a consumable. It is possible for it to be made in India also. We are coming out with that outlook in the next few years. So once these are done and you have a basic console, it shouldn't be a huge expense for a hospital as such. This is the model we are thinking of.
Sure, sir. Thank you, sir.
So definitely autonomous institutions like AIMS and government hospitals where they can cope with a dedicated team, they should come forward if it is possible in our setup.
Yes, sir. Thank you, sir.
Sir, good morning. Radhika from Guntur Medical College and the Department of Emergency Medicine, sir, at Guntur Government Medical College.
Please continue.
Sir, is there any training program that the university is planning all the doctors exposure
Can you repeat your question, please?
Emergency departments of
Signal is very low, sir.
government
Madam, signal is very low.
and, sir, can you hear me now?
You're not audible, ma'am.
Morning. Can you hear me?
No, Radhika. We couldn't hear you.
Sir, I am Dr. Radhika from Guntur Medical College, sir. I head the Department of Emergency Medicine,
Yes.
Emergency and Critical Care, sir.
We can hear now. Tell me.
Thank you for giving us this opportunity to connect with you all people, sir. Especially in the get trained first. So, is there is going to do the training program for all the government doctors who work in emergency and critical care, sir?
You'll plan from the university, I think, the Dr. Suneel Kumar will take as an advisor to the advisor for the ECMO.
Government hospital and the PG.
He's a student from Corporeal Membrane Oxygenation is not a problem. He'll be coming once in 3 months to India. I think we'll take some practical sessions also in the university itself, so that those people are interested, particularly emergency medicine department and all critical care. I think definitely in the future course. So this is after taking as a Vice-Chancellor 2.5 months back. I thought we'll be doing such a type of programs. Eminent people from the different levels, different subjects will definitely encourage the people, and we'll be conducting this WebEx meeting to all this one. I request the principals also see that the Department of Medicine, Anesthesiology and all, not only the principals are listening, I think the student community, postgraduate level on the medicine department and post emergency medicine critical department also, they should also listen to the lectures, great lectures, so that so we are very proud of Dr. Suneel Kumar is a part of our batch 1977 Sarfudaya batch from Corporeal Medical College. Thank you.
Currently, training programs are available from ECMO Society of India. But as Dr. Chandrasekhar says, something else we can plan here. I am very happy to get associated.
Good morning, sir. Program is very nice, sir. Thank you, sir. Thank you very much, sir.
Thank you, madam.
Sir, good morning, sir.
Good morning.
Sir, good morning, sir. Am I audible?
Yes, good morning.
Sir, I am Dr. Chandrasekhar, Professor of Anesthesiology and Head of the Department of Vish Medical College, Kurnool, sir.
Hello, sir.
At the outset, I like to congratulate Dr. Suneel, sir, for a wonderful and very extraordinary, because I am always attending regularly ECMO programs in Raw Online Chennai. You made it very simple, and you made it even now it is possible in our setups to have ECMO, especially under the able leadership and dynamic leadership of our VC, Dr. Chandrasekhar sir. I am really grateful to him. And sir, I worked vigorously during COVID-19 in Kurnool Medical College, Government General Hospital Kurnool, and also a private corporate sector in Gauri Gopal. Sir, how much would be the cost to set ECMO center under aseptic precautions, a center like private medical college or even government medical college setup, sir?
Infection control setup, it is mainly the principles, how you use your antibiotics, hand washing practices, the basic things. So those things I will leave it to you. Apart from that, the ECMO console itself costs around 20 to 30 lakh rupees. One ECMO console at this point of time. And the consumables, if you buy it from outside, it is between 1.3 lakhs to 2 lakh rupees from Mackie, for example. Or if you make it locally, it will cost you around 60,000 rupees to 70,000 rupees if you assemble it by buying different parts together to run the program. And daily running costs will be anywhere between 5,000 rupees to 8,000 or 10,000 rupees, because blood is also not needed every day. Now and then needed, blood products, etc. may be needed. That would be your running cost. So the running costs are mainly from blood and your antibiotics. These are the two. So the initiation cost is different from the maintenance running cost. Initiation cost will come to 1.5 lakh rupees approximately. In a government setup, it would be 70,000 rupees approximately, and running cost around 10,000 rupees, maximum 10,000 rupees per patient, including ECMO, ventilator, everything in a government setup.
Thank you so much, sir. I have two questions for you. One is, how frequently we have to change pump or oxygenator when it is a long-standing ECMO? Number one.
Yeah.
Number one. Number two.
Yeah, in an extreme,
Number two, sir.
we changed it after 60 days, 60. It depends
60.
on, yeah, that is not a standard one too. It can be anywhere between 10 days to 60 days, but we had instances when it lasted for 60 days. It depends on how you maintain your anticoagulation, not just within the right proportions, not excessive, not less with that. And if there are no additional problems such as clotting within the circuit or clotting of the oxygenator, they tend to run for 2 months without a problem. Circuit, generally we tend not to change it for the entire run of ECMO. It is the oxygenator if at all needed. The change of oxygenator, if the oxygenator is blocked with clots and gas exchange is coming down, then you tend to change it. It could be as less frequently as once in 60 days, once in 2 months, or it could be once in 10 days also. And we expect, if you start early, we expect ECMO run not to need for a longer period of time if we start early. I would like to put it, this is a limited talk, so I didn't include everything in it. I would like to take ECMO as a point of comfort. It is not luxury, it is a comfort. From a stage where you cannot ventilate your patient, where you cannot oxygenate your patient, ECMO gives you an opportunity to ventilate a patient and oxygenate a patient. At that time, decannulate the patient, come back onto your primary modality. Okay? Then without ventilator-induced lung injury. So that is the point in that. So that's why I want to stress, this is comfort and this is not luxury. You cannot wait till the patient is ready to go home, decannulation. No, not to that point. You have to optimize everything. We call it as window of opportunity. There are times when the gas exchange improves, when the X-ray picture improves and patient health condition improves, you have to come off at the right time. So this is part of the course as such. Okay.
And my last question. Yes, sir. Sir, thank you. My last question is acute to massive pulmonary embolism.
Yeah.
In your experience, what exactly is the survival rate, sir? With ECMO.
We know arterial ECMO is the choice at that time. 40 to 60%. Best survival rates are around 60%. In Indian scenario, if you add infection to that, it might come down to 40%. So without infection, it could be 60% survival rates. And it is a reversible condition too, that is advantage. It's a reversible condition too. And if you want to combine with surgery, you can still combine it with surgery once patients go on to ECMO. It is possible. So the survival rates are usually around 60%.
Thank you so much, sir. Once again, congratulations, and also I must congratulate our dynamic Vice-Chancellor, Sir Chandrasekhar, sir. Thank you so much.
Thank you.
Thank you. Dr. Suneel Pooboni sir is there, or Guru? So a few words.
Dr. Suneel and Dr. Chandrasekhar, I am proud. So, Guru Naminchina Sishyulu Iddaru. Then I gave them some concepts of general surgery when they were students, and that is the foundation. And one more thing is, that is, you have to inculcate the concept of academics when they are students. I am really proud to say, when a conference of Association of Surgeons of India, AP chapter was held in Siddhartha Medical College, at that time, we all of us came in a college bus in a big way. I made 10 students to present papers in Association of Surgeons of India state chapter. That was the only college, and one amongst them is Dr. Suneel. Probably it's, I think it dates back around 79. That's a year. And Dr. Chandrasekhar also similarly presented papers. That's how they came into academics and continued to be in academics. And Suneel, I'm really proud. Iddaru kuda VC and Professor Suneel. I am really proud that my students have come up in a very big way, and you have earned a global reputation. And Chandrasekhar, I have a lot of expectations. He is going to revamp, reshape, and he is a very dynamic Vice-Chancellor. You can see in future what things are going to happen, and he is always friendly with the institutions. It is not the whip, it is not the stick, it is the word, it is the motivation, it is the friendship. That's how the institutions should develop. He will never believe in the concept of punishing. Punishment is not the way of developing medical education. You should motivate, motivate, motivate. I am really proud to see Dr. Suneel and Dr. Chandrasekhar here. Thank you very much. I wish both of you all the best, and I wish many more laurels to come to you. Thank you.
Thank you, sir, for your kind words.
Any other questions? I think Dr. Suneel will be ready. We'll work it out, and yes, thank you, Dr. C.L. Venkata. You were our inspiration. When we were final year students, we used to go and listen to his clinics in the evenings and all. I think you are the role model for us, sir, and to come up this stage, everybody is responsible, and definitely our teachers. Without our teachers, we are not here. Definitely, I think the institution should grow. I think we'll take the Dr. Suneel Kumar with talking to the health minister and also secretary. He will be taking as an advisor for the ECMO, particularly Andhra Pradesh, to work together and to develop some regional centers. I think we can start these ECMO missions, and also we'll also welcome the private institutions, private medical colleges. So there are good private medical colleges also. We can start this one, so that ultimately we have to save the patients. So that is our ultimate job. Is we are professionals. We try to improve the standards and also the life of the patients. Anybody?
Thank you, Venkata sir. As Dr. Chandrasekhar said, you have always been our inspiration, and thanks for the kind words. We continue with our journey. My journey with ECMO has been nearly 25 years now, and it keeps going. We set up a base in India now. It is very well established. Next, from here, I'm moving on to Calcutta for our annual conference of ECMO Society of India. And next year, we're conducting our international conference in Chennai. So, people do have the regard for me like the founder, president of South Asia, West Asia, Africa chapter of ECMO, where we provided guidance to 89 countries. That was a very memorable period. When nothing was existing, we started the program and we started supporting people with education, mainly with education. Thank you, sir.
Thank you, Suneel, for his excellent presentation. I think the day may not be so far that we will doing the ECMO missions and training facilities for ECMO. I think the dynamic people are there around our own state itself. So various people have come with this from the different medical colleges. A small felicitation to Dr. Suneel Kumar before he leaves to Hyderabad. Thank you. Thank you all for your participation. I think regularly these type of programs will be done from the university. WebEx, we got almost 1,000 connections. I think in future, at least once in a month or once in 2 months, we will conduct these sessions by calling different people. And we thank you for your attendance and participation. Thank you. Thank you, Radha.